Good morning, everyone. Thank you all very much for this opportunity to speak today about the work I was part of last year in the Central African Republic as an MSF paediatrician, and the project that we carried out during my time there on reviewing paediatric mortality at the Regional University Hospital of Bambari between April and November of 2023. Firstly, some background. The Central African Republic is a very appropriately named country in the centre of the African continent, which gained independence from France in 1960. In that short time since independence, the country has undergone 3 civil wars, the most recent of which began in 2013 and known as Les Événements, leading to the displacement of over 500,000 people, widespread food insecurity, and very poor access to healthcare. Today, the Central African Republic is ranked second lowest in the world on the Human Development Index with a life expectancy of just 54.5 years. Much of the civil unrest and violence during this protracted conflict has been centred around the Ouaka province and its capital Bambari in the centre of the country where I was based last year. And although the situation has stabilised somewhat in recent years, the effects of this protracted conflict are still being felt by the people of Ouaka province. MSF's work in Bambari has evolved from what was initially a surgical-based emergency project to a child and maternal health focus, which is based largely in the community by supporting local health centres and health posts throughout the prefecture. However, MSF still supports the Ministry of Health-run regional hospital in its paediatric and surgical care through supply of medications and equipment, staffing and training of Ministry of Health staff. The paediatric areas for which I was responsible included a triage department of 2 beds, a 32-bed general paediatric ward, 10-bedded neonatology ward, a 9-bedded inpatient therapeutic feeding unit, which had capacity for overflow or isolation units, and a 10-bedded ICU, which was so named as there was occasionally some use of supplemental oxygen and there was a higher nurse-to-patient ratio. There were 3 nurses working in each clinical area at one time, and there were 5 locally recruited MSF doctors who worked in these areas alongside myself. And of note, unfortunately, the medical and adult medical wards were not formally supported by MSF during my time there. So there were many challenges to providing high quality care in this context, which included frequent ruptures of vital medications, which included IV antibiotics and even IV fluids. We had limited capacity for diagnosis. Our bedside tests included HemoQ, urine dipstick, and rapid testing for falciparum malaria, HIV, hepatitis B, and syphilis. We also had X-ray and 1 portable ultrasound machine. We also had limited capacity for the treatment of any non-infectious, chronic or congenital conditions, and no capacity to refer these onwards to tertiary centres. The staffing and capacity for observation overnight was challenging, as due to security concerns, no medical doctor was on site between 4:30 in the afternoon and 7:30 in the morning. So children who arrived or deteriorated during those times were assessed and treated with a limited stock of emergency medications by the medical students and the nurses who were working overnight. But a big challenge to providing quality care was a lack of data collection and reporting among the hospital staff. There was MSF data collection, which was reportable internally to MSF, which included demographics of admissions, discharges, and primary diagnoses. But this data was not routinely shared, reviewed, or reflected upon with the hospital staff. And records on paper charts were frequently mislaid, and the patient registers were manually handwritten, and they were not always accurate to the true situations on the wards. So the aims of our study was to implement a regular morbidity and mortality review as a means to incorporating quality improvement, to encourage reflective practice among the clinical staff, and encourage accountability for providing high quality care. It was also to inform focused training sessions for the hospital staff. So we reviewed all deaths which took place in paediatric clinical areas from April to November of 2023. An MSF doctor reviewed the paper registry in each ward on a monthly basis and also collected each chart following the death of the patient to record demographics and the details of the clinical course. Monthly presentation of these results took place for the clinical staff at morning meetings, during which we reviewed trends and discussed the management of the patients, and used this opportunity to review the relevant treatment algorithms and areas that we saw could have some improvement. Our results were also compared with a similar study that had been carried out in 2021 by my predecessor. The results of our study showed that between the 1st of April and the 30th of November of 2023, there were 2,524 admissions to paediatric wards, and there were 180 deaths on the premises, which gave us a 7.1 mortality rate of children under 15 years in the hospital. Looking at the distribution by location of death, more than 50% of the deaths took place in the intensive care unit, and more than 1/3 of deaths took place in the neonatal unit. So we saw that generally critically unwell children were correctly being recognised and transferred appropriately to intensive care. Unfortunately, there was one accidental death that took place in the inpatient therapeutic feeding unit during co-sleeping with a parent. There were 3 deaths in general paediatrics where deterioration overnight was not recognised, and 3 deaths in the triage department of critically unwell children and unsuccessful stabilisation. Looking at some of the trends, nearly 40% of the 180 deaths were in neonates. 44% of the deaths occurred during the day shift, where there were MSF medical staff on site, and 53% of the deaths occurred in male patients. Regarding the length of stay before death, we can see that nearly 1/3 of patients who died did so within the first 24 hours in the hospital. This truly reflects the unstable condition in which patients arrive, as delayed presentation is quite common due to traditional treatments and long travel distances due to poor infrastructure. There is, as I said, no medical doctor overnight, meaning that some of our admissions were going up to 16 hours before being examined by a doctor. Looking at the primary diagnoses and causes of death, in green we have the percentage of mortality attributed to each diagnosis last year compared with 2021 in blue. So we see last year that the leading cause of death was malaria at 30.5% of all deaths. Of note, for those outside the neonatal period, malaria accounted for 49.5% of all deaths. Malaria had overtaken prematurity as the leading cause of death in 2023, and other most frequent primary diagnoses included sepsis, pneumonia, perinatal asphyxia, neonatal infections, and meningitis. We did some sub-analyses in the neonatal department and those patients with severe acute malnutrition. So in our neonatal department, there was just under 20% mortality rate, with low birth weight or prematurity accounting for nearly a quarter of all deaths and 62.3% of neonatal deaths. A real challenge to the delivery of the quality neonatal care was that the maternity ward was not co-located with the neonatal ward and was not formally supported by MSF, having been supported quite recently by another NGO. And the physical distances between the 2 wards led to great difficulties in transferring neonates and supporting kangaroo care. And severe acute malnutrition was implicated in 11.7% of all deaths, and that was 18.9% of deaths outside of the neonatal period. Primary causes of death in children suffering from severe acute malnutrition included TB, HIV, and malaria. So the implications and impact of our study was that we were able to compare the results with our 2021 study, in which the overall mortality levels, there were more deaths recorded in 2023 than in 2021. Possible explanations include, I believe, more accurate data collection and reporting in the case of death, particularly for deaths outside of the neonatal ward. Underreporting of negative outcomes due to fear of blame has been historically reported. We also were able to collect this data monthly to the clinical team in the form of a traditional morbidity and mortality review, and we also supported an application for funding of a doctor's night shift at the hospital in an attempt to reduce that length of time in the first 24 hours to a medical assessment following an admission or a deterioration of a child. The high proportion of neonatal death that remained also supported creating a maternal infant health committee, which was composed of MSF staff and Ministry of Health and maternity staff, and that was aiming to coordinate the care between the two teams and to improve outcomes in neonatal resuscitation and the transfer between wards. And we were able to carry out Helping Babies Breathe workshops with the Ministry of Health staff during my time there. So I'd just like to say Singilimingi and thank you to a number of people who helped with the data collection, including Dr. Tony Singasau, Dr. Cara van Gunsven, and Madame Lorraine Racco. And I could speak about my time in the Central African Republic forever, but I think we're pressed for time. So thank you all very much for your attention.